with the idea of the title here, Do This Now, one of the things I want to make really clear, you got to be careful when you say do this now, you're not pointing to any part of your body. That's just taken inappropriately. When we say do this now, we're talking about procedures. My life has changed since I came to Stony Brook, and I'm really excited to be here with you guys. I'm part of a new academic community, and I'm just meeting them, and it's really kind of great. 18 programs. When I look out here, that's pretty clearly what Darwin had in mind with random mating. But 18 programs is unbelievable and really kind of cool. But I'm just sort of finding my way around, and I came from LA County, which is sort of a big, brawling, indigent, inner city, immigrant kind of hospital, where we saw a lot of gunshot wounds. When I came to Stony Brook, and it's a little bit different. First you have to find out where the spaceship landed in the woods. If you've never been there, you'll know when you get there. It's like, oh my God, it's a spaceship that landed in the woods. But I see different people, so I was working in the department the other day at Stony Brook, and my patients' ages in just my area added up to close to 2,000. And not because I was seeing a lot of people. It was because they were all between 80 and 110. So there are different things. So I'm going to talk about the dreaded ground level fall, which is not exactly an exciting topic, and it's frequently sent like to minor trauma. And it's mistriaged correctly, and we're going to talk about how to do this now without pointing to anybody. So yeah, there it is. And you can't really get the full spaceship vibe in the photo, but trust me, I know it's paying me money to be here. I'm happy to be here. Just as a mentioning of fellowships, we are now funded. I'm looking for 2 fellows to do international work, Chile, Brazil, Madagascar. Anyone interested in applying, I'm interested in meeting you, bring your language skills on Egypt. So let's talk about demographics. So one of the things that's happening, and it's happening all over the world, but in some places more than others, is we are getting older and older. In some countries like Japan, they forgot how to have sex. So they have the fastest aging population in the world. They do. Chile is number 2, and I've done a lot of work in Chile. The United States is in the top 10. And so once upon a time, there were these pyramids on the upper left where the old people were not many. And then they started looking more like Empire State Buildings as things sort of slowed down. And you reach a point in countries like Japan and Chile, and this is Chilean data, down on the lower right, where people get, the thing is all upside down. It gets fat at the top, which is just where we're going to now. And so you'll have shifts where it's hard because you're working in the emergency room, it's like 78, 83, 120-year-old, then 104, 110, 99, and so you try and access their old charts, and if you work in a hospital that doesn't have an electronic record, it shows up in a wheelbarrow. Like, oh my God. And it's, yes, you can get the information, it's just too much information. Which parts of it are relevant, that are relevant now, they're hard to care for. And when they fall down, even minor things like a little stub your toe that ends up in your minor trauma area and they have a ground level fall, you have to have real sort of fear about these people because they're brittle, they're fragile. So population aging, birth rates are dropping, older and more brittle. I view them as more or less not even real potato chips. They're synthetic potato chips. If you sneeze on them, they break. If you have, she got like 3 rib fractures because you too close to her when you do that. If you've seen me talk before, I'm not a huge fan of the pan scan that has gone wild and the general irradiation of the human populace. This is a place where pan scanning may have more utility because they're so fragile and the identification of injuries is so much more difficult. You know what the history is like, right? You go into a room, a 93-year-old, ground level fall. What's the history? Hi, I'm Dr. Mallon. Here's your history. You look down at the billing office, is that accountant's working assistant? That was 10, right there. And then you don't use an x-ray because it's safer. Here it is. The nurses can. So they don't actually tell you where they hurt, and sometimes they can't feel where they hurt, and so the whole thing becomes just that much more challenging, and even really minor mechanisms produce significant injuries. So this is just more news about people getting older and older and more Chile stuff. I've done a lot. I've been working in Chile for 20 years, so lots of that stuff. And it's all the same here. Japan and Chile are 1 and 2 in the country. In Japan, apparently, as I say, it's because I forgot how to have sex and no one really wants to anymore. In Chile, it's because divorce isn't allowed. So you better be careful about remarriage. Divorce is still illegal. So if you can have a longitudinal relationship with someone, for God's sakes, don't have kids because I think it's messed in a very Catholic, conservative country. And so that's one of the things there. So this is the usual story, right? You've all seen that things have fallen and I can't get up. You always have to find out. It's almost like stroke, right? When was your last upright time? Because they put them down for days, right? That could have happened last week, right? They could be rhabdo, pressure blisters underneath that. It's hard. And remember that in an old lady like this, you're not very, none of you are impressed with a CPK of 900, but remember, her whole body has a CPK of 1100. Right? So 900 actually might be high for her. So you got to kind of rationalize it and put it into the thing. And, these don't seem to be much, and as I say, they're frequently just triage. And there's lots of reasons they fall. I don't think it's a mystery to any of you. But you guys sitting here listening to me, you have really one crippling problem with assessing these people, which is that you're young. As I reach close to 60 and I'm losing my vision already, now the medical students, the damn millennials think I'm an asshole. I'm trying to help them with their personal status and things. They say, let me send you my availability. Really? You're going to send me your facts. But anyway, so when we think about these people, they're losing their balance, they might have had small strokes, they have ataxia, dizziness, there are way too many medicines. I was looking at a story of a patient the other day, this patient was 40. They came in and it was actually with a cheap complaint, it was some bullshit, some more bullshit. A lot of times, a little more bullshit. And then the meds started. I was impressed. I'm at the bottom of the page. On one med for every year of life. I was like, how do you do that? And I asked, are you taking all of these? And I was like, well, that's pretty much means you're employed. They said, yes. Because taking 40 medications like you're supposed to is kind of important. But these people are doing meds. We sometimes cause these gravel falls in the emergency room that people love. One of the things I've been impressed with at starting work in New York in general is the amount of sort of piss-hand bickering between services and pointing fingers. One of the things that's like a little over the top. No. I mean, it's starting work. It's like, I don't get it. There's like, I'll write a piece at some patient safety network. Really? Okay. But there's a lot of that. One of the finger pointing in this world, the old people fall world, if someone came to the emergency room and you were like, well, I can't believe I'm admit it, and she's a little out of control, start a little outlaw, maybe she'll be okay. You sit around. And next thing she's back with a broken hip, well, you caused it. So it's pretty clear that short-term prescribing of set hips and psych medicines in this elderly patient is a big contributor to falls. So the odds ratios of falls after receiving one of these prescriptions, a couple papers in the emergency medical abstract database, we talk about this, that point out that their odds ratio of falling is like 2 to 3 after getting a short-term benzo or psych med script. And all these other reasons they can't see stuff, they can't hear stuff. So those are reasons that they fall that are medical. And then there's all kinds of environmental reasons. See this right here? See, I'm too old to be on the floor like a cork. Because I have to go down. Not on it. I do this now. Okay? I'm wrong thought. I can fall over this, Here, let me show you how. Oh, no, I can't stop. That's it. That's how they go down. So there's all these sort of, people childproof their homes, and I saw the thing likes to play with cords. I would just point out that it reminded me, I plugged a tweezer that went out that when I was 5. That might explain a lot about me. And I blew up my father's TV from General Electric. It looked like a small Catholic church in our den. The whole thing, I blew every fuse in the house, melted the tweezer into the socket, and then did what any 5-year-old do. Put it back to bed. And when we got up late, because every clock in the house is stopped at 5 o'clock. Again, you guys are too young to remember, but there are some old people who are outside watching at 5 o'clock in the morning.
waiting for cartoons to start, eating Captain Crunch with the same tweezers. So the detectives, my parents, arose in the morning at 9:30 late, and they had to figure out who could it have been. Remember that game? Right? The candlestick, Colonel Mustard in the library. It was eating the Captain Crunch with the tweezers in the den, watching the pattern. Who could it have been? But it's like, oh God, I wonder if he's alive, and ran to the bedroom and they were actually snoring. But yeah, so we shop around, but we don't old-proof our grandparents' home nearly enough. And so, someone buys grandma the Adidas running shoes like she's about to go out for a 10K. Those rubber tips are terrible. So these are bad shoes, loose shoes, old shoes. Have you noticed old people have old shoes?
Yeah.
They're sloppy. Their shoes are sloppy. No misery riding them down. They're really sloppy old shoes that are 35 years. And God forbid you suggest the new shoes get this for you. Because they can't believe the new shoes cost more than $35. I'm not buying those. But anyway, so we gotta do this. Like this, that right there, that's a grandma killer right there. Right there. See that? We got the den and we got the hallway. Throw in something like a chihuahua running around, and it's over. You throw the chihuahua to suburban. No chihuahua, it's just a busted head. I give a lecture about international travel, and one of the things that's really not well appreciated, and particularly by your generation, is you guys think that flip-flops can be worn anywhere. No, flip-flops are a major cause of injury and problems. You know what that is? That's a flip-flop and a moped. Real close. Minus a color too, in Thailand. You got, when you really figure out, you learn to dive until toes flies over your head. Now, when a young person falls, has a ground level fall, one of you guys, you go up, you hit the sidewalk, get a little slip on the heel strike, boom, you go up like this, and then you have this choice as the earth rushes towards your ass what to do. And you're like, should I break the fall with my ass? Some of you might logically think, yeah, plenty there. Some of you will be like, not so much caboose here, but there's some protection on you, reach your hand out and you get a collar fracture. But with the old people with no padding, no reflexes, when they look like that, they don't get a hand out for a collar fracture. They're going straight down as shown over here. They're going to have injuries. And all of these are sort of the typical injury patterns that go with it. And old people always make smart decisions. She actually thinks that's vitamin D and calcium in rich smokes, because that's what they told her on the advertisement. So we're going to talk a little bit about hip fractures. And hip fractures have been around 4 to 5% globally, huge numbers. But you have to be careful when you're reading trauma registry data because it's not always in there. So some trauma registry data includes it, some trauma registry data doesn't. And I'm always amazed by these numbers. 1-year mortality, 12 to 37%. And half never regained independence. So when you see an old person with a hip fracture, you need to realize, you know, if you were playing a video game, the noise that would be associated with that would have to be. So you think, you kind of might have it in your mind that a hip fracture is something that can be fixed, but it's I mean, half of them are never going to regain independence. And sometimes it's a twofer. You'll see, you know, the couple come in, the old guy's got a hip fracture with the doting lady they've been married for 60 years around them. And so he gets into the hospital, he gets a pee and dies, and what happened to her? A week after he died, she'll come to her in cardiac arrest. Because she just died. You know, they needed each other. So some of these are even twofer deaths. 2 deaths for some hip fractures. As I mentioned, these are some papers on under triage. They get sent to minor care. Oh, they look fine. They're not screaming in pain. And their vital signs aren't bad. Hey, they're running tacky. Yeah, they were on 3 beta blockers and calcium channel blockers. That's why they were tacky. And their heart just doesn't go fast anymore. They have exciting syndrome. It goes 50 or 150. So they get missed. And you know, even these minor things. A lot of them have other problems with pathologic fractures. So there's lots of things going on. Environmental things, underlying medical things, etc., that are going to cause these people to be under triage. And the vital signs, I say, are all over the place. So do this now. Stop believing that good vital signs mean that old people are well. Stop believing that, because Good vital signs in old people don't mean they're well. So a blood pressure of 120/80 might be grossly hypotensive, might be shock in an old lady. That might be shock. Sounds right. Particularly if you see the 120/100 thing. You guys see that on the instrument exam sometimes, you might go by it. When an exam item writer puts 120/100, they ain't supposed to be 120/80. Why did they put 120/100? They're trying to tell you that the pulse pressure narrowed. That's code in ATLS for stage 2 hemorrhagic shock. Anytime the pulse pressure is narrow, it's code for stage 2 hemorrhagic shock. And so you got and weird stuff happens. They have time. You talked in the last slide about them having pathologic fractures and such, but they have time to have diseases. So we had a lady who fell out of a wheelchair, this was 2 weeks ago in Stony Brook, and she didn't look so good, and ultimately it turned out that she had a belly full of blood. Why? Because she had a huge spleen. Why? Because she had babesiosis. So basically it was tropical splenomegaly in Long Island. I was like, wow, weird. But there you go. So you got to be careful with these people because they have other diseases. Now, the trauma service, your trauma service, and I know it's a little bit like throwing darts at a blimp, right? Making fun of the trauma service. But really, you gotta feel bad if you're admitting an old lady with a busted hip or pelvis to the trauma service because they don't know anything about any of those diseases that she has. So you should pin the tail on the donkey. By that I mean, one, be really compulsive about identifying their medical problems and their med list and potential contributors. You need to be smart about the history. Which came first? Did you have a PE that caused the fall? Did you have a VTAC or some dysrhythmia that caused it, an episode of hypotension? You need to be looking for the medical precipitant of the injury and understanding that that's probably as big a threat to them as any of the trauma outcomes. And consult people that they would consult. Because they don't really love it when the cardiologist comes to the surgical intensive care unit for the old lady. Right? They're not. You think the trauma service calls them? You admit an old lady with AFib, you think they call them? No, they don't. So you need to get all of that rolling because they don't really like people looking in on their surgical domain. Because then what would happen if other people went to the surgical ICU? The stuff that they want to call expected deaths might suddenly be reviewed as not so expected. You can only get away with saying every death that happens in your service is an expected death if no one else looks at it. And so they don't really like other people looking at them in the surgical area. So consider getting the MICU or IM or CARS involved. You need to be thinking about things like what happens when you give the little potato chip with a GFR 25 a huge dilode as part of their pain scan. You need to think about those things next. And you need to think about when more advanced imaging is needed, like an MRI. We're going to talk about doing that now in a moment. So this is the other thing that I learned at Stony Brook. So I was in this little indigent hospital in LA, seeing our 700 a day or 600 a day, and people were young and they were sick. Don't get me wrong. People at LA County were very sick, but they had sickness like in one place. Like Occam's razor actually worked there. Occam's razor doesn't work on these older people with these pelvic falls, pelvic trauma, and it doesn't work at all at Stony Brook. So I've had to relearn the opposite of Occam's razor, which is sickness victim, which is patients can have as many damn diseases as they like, and so they're fighting out. But Occam's razor is dead at Stony Brook with these old people. It's just not true. So I looked up some things. There's this geriatric EM cast. I don't really listen to it because I'm too old and out of touch to be in touch with those things, but I looked it up anyway. And then there's Life in the Fast Lane. These are actually all a bunch of quotes from Life in the Fast Lane. What an old lady. These are the quotes from Life in the Fast. You guys know Life in the Fast Lane, right? From the Kiwis and all that stuff. There's Nixon and all. And these are what they say. An old lady would tell you when she comes to the emergency room with a ground level fall. 1, I can go from normal tension to crashing fast. 2, fluids could be a big problem. Either too much or too little. You can't just say 2 liters wide open on a little old lady with CHF. Because you'll be chasing it with Lasix in a moment and it won't look good. I only look like I have pulmonary reserves. They don't. Demand ischemia is my middle name. Anything you lead to, they're going to end stemming out on you any moment. You can leave a young person tacking away at that I'm bleeding to death heart rate of 140 for a little while you play catch up, but you can't do it on these old people. And my abdominal exam is useless. This is a picture also from my past. I like the screech. If you notice, the tires on the inside edge of that curve are off the ground, with flames shooting out the back. So this is what you get, you know, they come in, and so you do this now, which is get a pelvic X-ray, which is, let's face it, what is that? That's a blurrogram of somewhere in here. You don't really have much to go on, and you might see a fracture, and you do, but by all means, if this is what you saw, and then somewhere along the line, you think it's time to get grandma up, and grandma or grandpa won't bear weight or walk. If they won't walk, then you're not done. So at that point, it's automatic. Because the rate of occult fractures, again, multiple large series, if you were to go to the Registries abstract, say that the rate of occult hip fractures, we're just talking hip now, occult hip fractures is around 4.5%. So 1 in 20, 1 in 25. You're going to see way more old people than that. So you're going to see these, and if you think that an AP pelvis in the hip is going to be good enough to find them, it's just not. No matter how much you use the patch magnifier and think that you can follow the trabecular mechanor making the X up at the top of the femur, that's just not happening. So you're going to have to go to a higher level of imaging. So this is actually, these are all real films. That is a broken hip. This person wouldn't bear weight. And we'll have it in a moment. So AP pelvis, low sensitivity for hip, super low sensitivity for sacral fractures. And I remember when I was president, what did we think about sacral fractures? We didn't think about sacral fractures. No one did. It's like, who cares? Why make the diagnosis of stuff that it did? Yeah, it's a pain in the ass, literally. The broken coccyx, I remember reducing a coccyx fracture on a rectal once. Someone told me to do that. Don't do that. Unless you have a really good reason to do that, don't do that. You can do that, but don't do that now. Okay. Anyway, and so while CT is good for many of these, MRI is better. We have a few now head-to-head studies comparing MRI and CT where MRI wins. If you don't have MRI, lots of hospitals don't. It's not available. I think CT is just fine. But you should know that MRI is a little bit better. It finds a few % more of these injuries than CT. And I remember the days when I thought that, well, I thought CT was better for bone than MRI, and that's just not true anymore, right? With MRI, if you stir it up, right, if you want to hang out and gain community with your radiologist, you have to know these terms. So stirring it up stands for short tau inversion recovery. MR is very good for bone. And so we'll find fractures. And remember, what you don't want to do with these is have, right, what's the main reason, and by the way, this is another thing I noticed about New York. Y'all are scared of lawyers, man. All they do is talk about lawyers this summer. Where are they? And they make me take these, the hassling factor in New York is high. Like I had to pay $60 to show that I knew how to wash my hands to the Nursing Society. I was like, where was New York ASAP? Who fucking fell asleep at the wheel on that? I mean, and then they wanted me to have all these trauma credits. I'm like, I lecture trauma all the time. They said, no, we actually need the certificate. So I had to take my lectures. And then the challenging part was the eval. I was like, I was kind of caught between really insightful, articulate presentation and who was that asshole? I didn't want to each. Just to be fair, the evaluation process is easy. But the real issue with the lawyers is FTD, which is not floral service. It's failure to diagnose, leading to failure to treat, leading to failure to consult. And so if you go with plain films on these elderly people with ground level falls, you're going to miss stuff. So to do this now, part of that is get the advanced imaging if they can't walk. Notice I said, get the advanced imaging if they can't walk. Not get the advanced imaging on everyone. It's get the advanced imaging if they can't walk or bear weight. If you have a clinical reason, not as a surgeon would be, I heard this test was better, we'll do it on everyone. There's a difference between those two approaches. So, this is that same AP pelvis I showed you, and it shows you just how sneaky it is. You can just see the little click, right up there. Just imagine a potato chip going. That's it. That's all she's got. And if you don't find that, if you FTD that, failure to diagnose that, and then she moves and snaps that off and it becomes angulated, it changes from a small surgery, right? What will an orthopod do with things like that? right? They'll big little hole in the skin with a leather blade, and then they'll go down to the bone, and then they'll put a screw next to that. Done. That's 3 screws. And then we'll step away from the old lady. And if you don't find that diagnosis, and the thing clicks off, and now it snaps and it's angulated, now it's an open reduction in internal fixation. It's a 6-hour surgery, and imagine the orthopod swearing into the can't get things where they want them, and there's plates that gotta go in there, and you like her weight's twice as much as it was before because now she has metal in her. And then it becomes a big thing. She gets an inpatient stay, and then she gets her PE, and then she gets urosepsis, and then she falls out of the bed in the hospital on the tile floor, which is slippery, smacks her head, gets a subdural, you know what it's about. You've all seen it. So no, you don't want to miss that. So occult hip fractures, as I said, 4 to 5%, go to the CT if they can't bear weight or have trouble walking or other suspicions there. If you have it available, ask for the MR. Because some of these people have pathologic fractures, some of them have extra articular and extra bony findings that are relevant. So if you have the MR, get it, it's better, but if you don't, the CT is just. And this just shows you what you're going to find when you go there in terms of CT scanning. And so there are all the usual things that you expect about the greater trochanter neck are high, and pubic rami are high. And notice the acetabular fractures, those get missed a lot. So the big misses are in there for if you don't go there and get the advanced imaging on the acetabular fractures. When you say acetabular fracture, they're called type 4. There are different classifications for pelvic fractures, but usually they're their own category because each of them never walk again. If you have an acetabular fracture, you're going to live for the rest of your life. And then there's not that many sacral fractures, but they get this a lot, and I'm going to pay them a little attention in a moment. So plain films for sacral fractures, only 10% sensitive. That's because there's a lot of acid left. You do that, right? It gets blurrier as it gets farther away from the thing, so it's blurry. There's a lot of acid left. And so, but they're highly associated with pubic rami and symphysis fractures. And early mobilization of the patient requires early immobilization of the fracture. Right? You gotta stick the fracture in place, then the old lady will get up. If you don't, if it's moving around, she won't get up. And that's become very clear. And lots of stuff has changed with these things. There's a very subtle click. Oh, this person had an inferior superior rami fracture that was found, and on hospital day 3 got the advanced imaging and we found this. And as I say, it used to be we didn't do much about this, but now we do. So now there's sacroplasty with glues. There it is again. That's a fracture. It's pretty obvious, but you can just imagine that step off being a lot less over there. And there may be some blood loss associated with these, there may not, so you got to keep that in mind. And Dennis classified these, I don't think this classified, Dennis did the 3-column concept of the spine. If you don't, that one you need to know, the 3-column classification of the spine. I don't think you need to know Dennis' classification. Dennis apparently wasn't that smart. I mean, he was an orthopod, who basically, whenever he decided to classify something, divided it into thirds. I can credit the body into thirds, it's kind of cool, but he divided everything into thirds. There's a caterpillar, woolly, divided into thirds, the tan bar, the black bar, the tan bar. Divided into thirds. Now, some things and the foramen on this drawing are, you know, when you look at the drawing, like that's not the foramen looks like. So let's go back to that. That's what the foramen looks like. The only reason I show you the foramen is just to remind you that if you're looking for neurologic deficits, they often won't be there because the foramina are big relative to the nerves. And even bigger if I go to the obturator foramen and things like that. But the foramina are big, so while neurologic injuries can happen, they don't often happen with these little old ladies with ground level fall. So if you're looking for neuro, you should look for them, but they won't be there often because of the size of the foramina. And then in terms of the autonomic nervous system, they're all already, by the time they enter the pelvis, they're all plexoid in nature. So it's very hard to injure a plexus of nerves. You might get a little branch here and there, but you can't get the whole plexus. So there you go. And so when I was a resident, it didn't matter if you missed these fractures because there was nothing to be done. But now we do things and we know that it makes a difference because as the population is aging and more of these fractures are happening, there's more fixing of these sacral fractures with sacroplasty glue, as shown in the picture, with percutaneous screws, with transsacral bars, and not much in the way of X-fix, because that's sort of dying an ignominious death. So it's sort of a dinosaur looking for a target. But the top three are going a lot more. And we know that it's making better outcomes and that grandma and grandpa, when they have these sacral fractures, get up much quicker when you address their sacral fractures. So the sacral fractures matter now because there's something to do now that we didn't do 10 years ago, even 10 years ago, certainly not 20 years ago. Pain relief, yes, take care of pain relief. You know, these people are very worried that the gig is up. You'll see people with these fractures and they know that they're about to lose their mobility, they're not going home, they're going to end up in a rehab, so they're anxious about it. So that's why they refuse morphine and refuse dialytic, because not because they want to suffer because they're old people, not because they're insensate in old people, but because they want to keep their wits about them while people are talking about snatching their house. Who's going to snatch the house? It's not the gypsies up and down the street through the driveways. It's you, the doctors, and the medical bills, and the situation, which are going to send her to a rehab that's going to result in house being snatched. So they're rightfully concerned. So you should offer ultrasound-guided blocks and things like that. Yes, the irregular pressure paper is real, but I don't think that's where you go. There, honey. Does that feel better? Even if she says yes. There's a paper that says work with that. Oh, it says here. It's just the ultrasound. I'm trying to get it together. Yeah, it doesn't have to start play. That. Oh, there's this. You guys know how to do these, yes, now? The three-way block, this shows you your landmarks. Trichrate, nerve, artery, vein, empty space, lymphatic, you all remember that. And so, if you know where those things are, the nerve is right next to the artery. If you can do an ABG below the inguinal ligament, you can do this block. The nerve is at exactly the same depth. But nowadays, we want you to do this. Now, okay. Help me. This is why I don't. But this is just, you're going to have some ultrasound guided fairy come in and over voice. Did you get it? I'm going to look around the curve. Oh, there you go. That was close. I think you missed by that much. The hell with it. It's, you guys know what this looks like. I'll tell you a better story. When I fell off my motorcycle and broke my arm, I was getting a brachial plexus block. And they turned my head so I had to actually look at the screen while this spaz with bad hands tried to do a brachial plexus block on my left arm, which had an open fracture dislocation of my own. So I'm looking at the screen, they got my head pinned there so I could get to my brachial plexus. And I see the needle, good. And I see the nerves, little tiny, good. And then as she moves, I see the needle, but never do I see the needle and the nerve together. And so then she goes, there, you feel numb? I go, what'd you do? She goes, well, I just injected the lidocaine. I go, but they weren't. I was like, you're supposed to see the nerve and the needle, not the nerve or the needle. And so she dumped it, and then she touched my open fracture, and I screamed. She goes, oh, you must be lidocaine resistant. I'm like, you can imagine how that went. So then I started getting lippy with them, and then somebody said, fuck it.
Needle touches the fascia.
There you go. This is her now.
And essentially separated between the two layers of the fascia iliaca.
It doesn't show that good though. Does that show better?
Injection of local anesthetic causes separation of the two layers of the fascia, and the distribution of local anesthetic is clearly seen engulfing the entire femoral nerve between the two layers of the fascia.
And when that happens, because I had this done, the nerve is gone, like almost instantaneously. That's why when she said, I think you might be resistant to lidocaine, I said, my ass. And it worked every time I go to the dentist. And then I started complaining about it, and then they protocol me out. Many people, I think, by chair, have wanted to propofol me. Inconvenient truth, propofol. So there are lots of benefits. What do we know about these hip fractures, these sacral fractures? We know that the sooner you do the surgery, the better. We know that if you admit him to a surgical service, what happens next is that anesthesia comes and says, oh my God, this patient needs a doctor. And the surgeons kind of look around, they go, no, we need someone that can handle like a low GFR and AFib and the anticoagulation like a doctor. They're like, oh, we'll call one. And then that delays the surgery, then they end up having problems, they get up later and slower, and then we're back at the, the DVT and the PE and the urosepsis and all of that. So there's even some suggestion that hip fractures in the literature they don't like this, the surgeons don't, but they should be admitted to medicine because they need a doctor. The ACS, American College of Surgeons, wants all trauma patients to be admitted to surgery. To which my response would be sometimes they need a doctor. As I mentioned, pay attention when you're looking at registry data because it doesn't always have the hip fractures in it and the ground level falls in it, and it should. And this just shows that how, it kind of reflects how we feel about this when we're working in the emergency room, which is that the old lady is not really a joy chart to pick up. Right? You're not thinking, oh, I can't wait to dig into that. And so here you see what were we publishing, and we were much more interested in guns, even though there was prohibition on some gun research, we were much more interested in guns. And now we're finally waking up to the old people. There's the old people red research going up. And here's the piece saying, kids, they can find trauma most of the time, unless it's their head. So, in summary, do this now, beware of falls in the elderly. Do this now. If they can't walk or they have significant pain, go to advanced imaging. If you have MRI, do that instead, if you have it available. Consult early, consult other people. What is the saying, again, if you were worried about the lawyers around the corner, what's the saying for the young ones in the audience, which is right? If the person might have a bad outcome or even die, you're thinking, what is this? Never carry a coffin alone. Call consultants. Get consultants involved early. Never carry a coffin alone. Admit them early and try and encourage your surgical colleagues to operate on them early because the sooner you get them up and out the door, the better they'll be. Thank you so much for inviting me. It's been a real pleasure. I hope to meet a lot more of you in